What's up? Good evening, everyone. Good evening, good evening. Hope everyone's having a great evening. I actually don't know what day it is. I think it's Wednesday. So we'll wait for some more people to jump on. We're going to be doing a live demo today on the placement of ribbon fiber. This is going to be in a pretty large MOD restoration scenario. So the maxillary premolar we're going to be working on. Already got it set up here on the Typodont. Rubber dam in place, pre-wedges. This is an old restoration that we'll be removing. We'll be prepping this out with the B&R Micro Series hand pieces, my biomimetic burr block, and Comet burrs. And what we'll do is we'll walk through the gold standard bonding steps and then the ribbon placement using ribbon fiber, using Carrare's Clearfill APX composite. And we're also going to be using the Clearfill SD Protect as our bonding agent. If we have time, we'll go ahead and we'll restore the entire tooth with proximal walls. We'll go through the whole thing. I'm just going to give a little bit more time for people to jump on. It's 8:02 p.m. here in the Pacific Northwest. Under the microscope now, got everything set up. Why don't I go ahead and just walk people through what our armamentarium is this evening. Go ahead and pull the phone away. So here's what we're working with. This is a maxillary arch. I've already placed the clinician's choice purple non-latex or synthetic rubber dam. It's a very nice rubber dam we've been playing with. So we have the wood wedges in place, and we'll be prepping this tooth out here live in just a moment. Also using my custom Comet USA burr block. This is the biomimetic burr block. If you want to follow it on Instagram, biomimetic burr block. It is a beautiful biomimetic restorative burr block here, both direct, indirect, and the Q finishers with the polishing to achieve a very high shine polish, not to mention the Ceratep burr for just really easy on the fly soft tissue recontouring and gingivectomy. So we'll be using that today. As you can see, we're using the Clearfill Majesty Flow for the resin coat. I have the Clinician's Choice composite gun here with APX loaded, and we have the SE Protect Prime and Bond bottles. Also going to be using, if we get to it, these Tor sectional matrices. These are very nice matrices I've been using lately. And then of course we have our instruments. This is a Composite Ninja for trimming composite, and I like the round condenser, a little hockey stick, and a nice solid Explorer. And of course, last but not least, ribbon scissors and ribbon fiber here to play around with this evening. And I've got our B&R Optima system hooked up with the Micro Series electric handpiece ready to rock and roll this evening. So lots of stuff to play with. Looking forward to a great evening with everybody for this demonstration. Let's get started. Looks like we got about 25 people on board. If you have any questions, I'll be watching. And don't be shy to jump in. So obviously, you know, we're talking about ribbon tonight. And so what is Ribond? Ribond is, a fiber that's very popular within the biomimetic community, and it has a lot of benefits. And so there's a lot of research that's been done on Ribond fibers, mostly by Semabelli or Dr. Alireza Sadr. I think Dr. Alleman's also done some research with it. But what we're really trying to do here is, in a deep restoration, we're trying to ensure a very high secure bond to the dentin floor. And what happens with not just your adhesive, but also your composite, is you get shrinkage no matter what. A lot of companies out there will say, oh, we only have 1.24% shrinkage in our composite. That's so great. That is great. Every composite has shrinkage in it. What you have to understand is that the shrinkage has to go in a certain direction. Most of the time the shrinkage is going to go to the strongest bond being enamel. So if you're bulk filling a composite in a 3 to 4 millimeter cavity, the composite's going to bond to the enamel at the top, shrink towards the enamel. It's going to pull away from the dentin floor almost immediately. And Dr. Sadr showed that in his OCT studies. And so what we're trying to do here is we're trying to build a restoration from the bottom to the top, ensuring a very strong and secure bond at the dentin floor. So by placing the Ribond fiber, you're actually going to control the polymerization shrinkage, and you're going to reduce that because the fibers will disrupt the shrinkage and make sure that it goes down rather than out. You're also going to increase the microtensile bond strength. Dr. Semabelli showed this, and that's going to mitigate C-factor issues in your restoration. So let's get going on the demo here. What I'm going to do first is I'm going to prep this tooth out. All right, so let's switch over to the high-speed handpiece here. Now this is the B&Air Micro Series handpiece, and I have a deep purple burr in here right now from the biomimetic burr block. And so we're just going to go ahead and get started. We're going to remove this old restoration. And with these electric handpieces, are really nice because you get constant torque. So no matter what you do here, this handpiece is always going to be at a very consistent, constant torque. It cuts like butter, it's very smooth, and you have a lot of control. If you're used to using like an air-driven handpiece, like a star handpiece, especially with the slow speeds, and especially with the very old slow speeds, you're going to notice that you get the handpiece will actually catch on the tooth. You might actually get the handpiece rolling off the tooth. And that's because when you press harder, you're cutting through a tougher material. The handpiece does not have a constant torque, and it'll catch. So electric handpieces, super nice if you want to do very precise and controlled dentistry. So I want to make sure we remove all the old composite. Very tough thing to do, as it'll often blend in with the tooth structure. So if you're getting close, one of the things I like to do if I'm not sure if I've removed all of the old composite, and that's important to do because that old composite likely, if you're replacing it, it likely isn't bonded to the tooth anyway, so you really want to make sure you try to get rid of all of it. But you want to do it in a very conservative way. So, at this point, clinically, I might do some air particle abrasion, and what that does is it'll condition the dentin to a very frosty yellow consistency and color. And if you're familiar with it, and then what it'll do is it'll scuff up the composite, so you can actually see the composite. If you don't have air particle abrasion, what you can do is you can just use your phosphoric etch, and the etch will actually give you very similar display, so that you can determine if you've removed all of your. The etch is not ideal because then you'd be etching your dentin, and if you're using a dentin bonding agent like SE Protect, you're going to run into issues. So air particle abrasion would probably be the best way to go. Now you notice I'm being very careful about how I'm removing this, and you want to make sure that you work from the outside in. Because we obviously don't want a pulp exposure. If you've read Dr. Alleman's paper on selective caries removal, you'll know that you want to stay within about 3 millimeters here in the proximal box area from the adjacent marginal ridge to ensure that you're not going to expose the pulp. So you can see that now that I've kind of cleared things out, I'm going to kind of work my way diagonally with the constriction of the tooth, but I'm staying within that 3 millimeters so that I don't get a pulp exposure. All right, so we're just going to go ahead and just really fine tune this preparation so that we can go ahead and start our bonding protocol. I'm noticing here there's still some old composite, so we'll go ahead and we'll remove it. Now, one thing that I should mention is that a lot of people don't understand this is we talk a lot about hierarchy of bondability, and a tooth isn't just made out of one substrate. We have the enamel on the outside, and then we have the dentin. But we don't just have the dentin, we have superficial dentin, and then we have deep dentin. And so you're dealing with different layers of dentin, and the deeper that you go, the more challenging it becomes to bond to it. And so it's one of the reasons why we recommend a double bottle adhesive or bonding system, because the hierarchy of bondability is going to change as you maneuver your way through the different layers of the tooth. So on the enamel, you're going to get, generally speaking, you're going to get a very instant bond to the enamel. And of course, if you're using like a universal adhesive on, like an incipient lesion that's really small, that'll probably work out just fine for you. Once you get into the dentin, and it's deeper dentin, then you have to start considering, the different substrates you're dealing with and their bondability. And we know that we can achieve higher bond strengths to dentin than enamel with the right materials and with the right protocol. So, composite restorations, to many people, are made to seem like they're very simple and routine, but in fact they're very complex, and they're actually very technique sensitive. And if you want to do them right and make them last a long time, this is what you want to do. If you want to replace them every 3 to 4 years, then you can, use a universal adhesive and bulk fill. We prefer to do what's best for our patients and use the materials the way they're designed to make the restoration last for a long period of time. So we teach these techniques, I should mention, here in Seattle. We have hands-on courses. Not only do we teach the cosmetic side, black triangle closures, diastematic closures, peg lateral rejuvenations, composite veneers, but we also teach posterior composites. So if you want to go to injectionovermolding.com/store, you can check out the course offerings. We also have a demo on there. And you know, we have some courses that are still available this year. They're selling out pretty quickly, but our advanced posterior course in June, we have 3 slots open. We have another advanced posterior course, I think, in August. And we have about 4 slots open for that. It's a 2-day course. Dr. Davey Alleman flies in from Utah. He's our guest lecturer. And we have a great time during that 2-day course. So I highly encourage you guys, if you want to learn this and get hands-on, to come and join us. So we have a ton of fun, and people from all over the country, even overseas, fly in to take the courses. So, all right, so here's what I'm going to do now that I've kind of cleaned that old restoration out of there. I'm going to switch over to my slow speed, which is a 1:1 micro series, and then I have my mandrel and my disc on here. I'm going to run this disc at about 12,000 RPM, and what I'm going to do is I'm just going to kind of clean up the proximal areas, make sure that I remove all of the old composite and adhesive and get this really nice, clean, fresh enamel. We talk a lot about biomimetic dentistry on Instagram, and there's so many people. It's amazing kind of the cases that people are posting and the content people are posting to kind of up the ante and talk about how we really should be doing dentistry today rather than, you know, the old insurance-driven model that forces you to, you know, do average composite work that doesn't really last in a very short period of time. So I'm just cleaning up the tooth. You can see there's some composite here. Someone asked me in the comments, I'm seeing it over the scope here, they want me to show them how to measure that 3 millimeters. 2 to 3 millimeters from the adjacent marginal ridge. I'll do that right now. I don't think I have a perio probe, but I'll use an Explorer. I might have a perio probe might magically up here. We'll see. All right, so this is actually a typodont tooth that has a dentin layer in it. So that's very nice. This is the tooth that we use in our courses, so you can see that it gives you sort of more of a realistic vision of what a real tooth looks like. All right, so I'm going to use an Explorer here, and so what I'm talking about when we're talking about measuring from the adjacent tooth is, if you can imagine this is a perio probe, you're going to line up that 3 millimeter mark from the marginal ridge here. And you don't want to, see, I knew that a perio probe was just going to magically show up. So you don't want to go, you know, this is probably, looks like about 5 millimeters deep here down in the box. And so outside in the outer region of the tooth, that's fine, because we're well aware of where the pulp is. But if we try to remove any decay or tooth structure further in, we're going to run into issues because we're going to get a pulp exposure. And so in Dr. Alleman's paper, there's a lot of really great illustrations and photographs that show this, but what you're really looking to do is something like this. Now, if you know your burrs really well, you know your armamentarium, you know your round burr sizes, you don't have to stop all the time and measure this, because you can just use your burrs as a guide, knowing what the width of those burrs are. And so it's about 3 millimeters right there. I'd say we're safe. And from the distal, we can see we're pretty safe there too. We're probably not going to have a pulp exposure. And this is pretty consistent across all patients, but of course every tooth is different and unique. You have younger patients and older patients, so you always want to be aware of where you are, especially as you prep a tooth and kind of lose your guides and lose your perception of where you are once the cavity is opened up as wide as this one is, for example. All right, so you can see that we're about 2.5 millimeters down on the occlusal. We're in the dentin, and like I said, we're about 5 millimeters down on the proximal areas. On this tooth here, we've maintained sort of this enamel shell, and on both sides, that's very nice. It gives us a level of bondability to achieve a nice seal with the enamel there. Okay, and you can see that right here in the middle, if I mag up, I can tell there's leftover composite. And so, clinically, I would come in here with either air particle abrasion or a pretty large round burr. But if there's no adjacent tooth, use your burrs as a guide. You need to know and understand your burrs. So there's actually a really nice product that Comet USA makes, and it's this, let me see if I can come out, and it's this little dongle here. I have it on my keychain because I'm a nerd and I carry it around with me. But what this is a guide that shows, so you can put your burrs in there and measure your burrs. So I have a round burr on my handpiece right now. This just happens to be the number 6, and I know that. So I can place this inside these holes, and if I didn't know where the burr came from, I now know what size it is. But you also have this little ruler here on the side as well. So for any burr, like the deep purple burr here, if you're not really sure, and you should know, the specs of your burrs, that's something that we emphasize, because it saves you time. You can determine, the size of your burr at the tip, and then you can also use this to measure your burr. So, nice little tool from Comet USA. Goes everywhere with me. I've never seen a burr this big, but maybe there is one out there. The bigger the better, right? That's what they say. So anyway, let's go back to this tooth, and I want to show you just how to flake off some of that old composite. Now, the B&R handpieces are nice, like I said, because you have a lot of control and constant torque, so you don't have to do a lot of work and put a lot of pressure. When you're in an area like this where you really want to clean this up, but you don't want to remove too much dentin or go any deeper and risk a pulp exposure. So I mean, look at this. This burr is just spinning perfectly. It's totally concentric. It should be. This is a brand new handpiece and this is a brand new burr. But if your burr is wobbling, and especially if your burr is dull, then you probably want to do something different. Get a new one. Anyway, you can see how the composite here inside the tooth, let me center here, you can see how this is just flaking off. And so I'm removing that composite, but I'm not removing any tooth structure. It's a really nice way to kind of go in and make sure that once we go in here and we bond, that we're bonding to tooth structure, we're bonding to dentin, we're not bonding to old composite. So I'm not going to spend too much time here getting too crazy with this, but You know, in a real tooth, this is going to be a lot faster process, and it's going to be easier to distinguish than it is with this plastic tooth. But I would say that looks a lot better than where we were before. Okay. So, like I said, if we're using the burr as a guide, this number 6 burr is in the Biomimetic burr block, and I use this almost exclusively with the larger molars, because I know that if I use this round burr, I'm going to be very safe if I don't go wild with it, and I just stay on the outskirts of the tooth. The width of this burr will keep me safe from any pulp exposures. Okay? So now that we've sort of removed that old composite restoration, we can go ahead and start moving on to talking about rib-on. So again, rib-on would be indicated in this case because we have areas of this preparation and cavity preparation that are beyond 3 millimeters, and we're bonding to deeper dentin. And so, what we know is that we can bond much stronger to dentin than enamel. We're talking 50 to 60 megapascals with a gold standard adhesive, with isolation, and with a very strict bonding protocol. You can bond, about 30 megapascals, 20 to 30 megapascals to enamel. The bond to enamel is almost instantaneous, while the bond to dentin takes some time. And so we'll talk about decoupling with time. It's simply the concept of slowing down and allowing time for your adhesive to form the bonds into the dentin. Now, the dentin is a wetter substrate, and it just takes time for those bonds to sort of form and mature. And you don't want to go beyond a millimeter or two without waiting about 5 minutes for that adhesive. All right, so I'm going to go ahead and do you bevel the enamel? Yeah, so I always bevel the enamel. You want to bevel the enamel to put the rods in an orientation that's optimal for bonding. You don't want any sharp line angles. It's just not conducive for placement of composite. So I'm going to go ahead, and this is the Clearfill SC Protect Primer. My assistants ask me all the time, do we need to cure this? No, this is the priming step. You just want to scrub this in place for good 30 seconds or so, really scrubbing it into the dentin, but I'll always come and scrub it into the enamel as well. This is going to serve as your self etch, conditioning the dentin. Now I always do this after air particle abrasion, so once the tooth is prepped out, as we started here, I do air particle abrasion just to condition all of the enamel, clean the enamel off of any biofilm, and condition the dentin for the bonding step. Okay, so as I'm talking here, about 20-30 seconds have passed. I'm still scrubbing this vigorously into the dentin layer. And then all we're going to do here is air thin this for about 10 to 15 seconds. Now you still want to have sort of a wet look, but you want to air thin it to the point where you don't get any movement of the primer across the tooth. And now we'll move on to the bonding steps. I'm going to go ahead and throw the filter on. And this is the SC Protect bonding step. So we're just going to go ahead and use a drop of this. Now there's a lot of practices out there that are very stingy, right? And the assistants are trained to be stingy, and that's okay. You don't want to be too stingy with the adhesive. You still need a decent amount of adhesive to form the proper thickness of adhesive across the dentin that you're bonding to. So I'll always make sure that I have a decent drop on the end of the microbrush so that I can see it and I can spread it and scrub it. Some assistants have handed me a microbrush that I could tell was just barely wet, and that's just not going to be enough to ensure that we have a secure bond to the tooth. You also don't really need a gallon of adhesive either, because you don't want your adhesive layer to be too thick. So what you'll see me do here in just a moment is dry off my microbrush, and then I'm going to come in here and I'm going to just sort of mop up the excess. I don't want any pooling of the adhesive. We're not going to air thin this, because when you air thin it, you introduce air into the adhesive layer, and that disrupts the bond formation. And so what you can do here is just sort of thin this out, mop up any pooling that's occurring, and then we'll go ahead and we'll cure this for a good 20 seconds. Does anybody have any questions so far? I see some questions coming across the screen, which is great. Cat's meows here, which is always nice to have. Cat's meow. Talked about beveling the enamel. Again, we love teaching all of these concepts in our Injection Overmolding Institute. Follow us at institute.io on Instagram. Go to injectionovermolding.com. You can learn about our 2021 course schedule. We do anterior and posterior courses. The only thing we're teaching this year is our advanced posterior course, which is a 2-day course, and that course is guest taught by Dr. Davey Allman. He flies in from Utah and hangs out with us for a couple days, so really fantastic time. That's a good question. I have a plastic tooth right now. Do we etch the enamel? So there's a couple different ways to, or there's a couple. Some people don't even bother, because the self-etch step on the enamel, the bond versus selective etching, some people believe is so small that it doesn't really make a difference. Some people will go ahead and do this next step, which is the resin coat. What we want to do is come in here and we want to place a very thin, no more than 0.5 millimeters of flowable resin over the adhesive layer. And once I cured the adhesive layer, by the way, that 5-minute timer starts for the 5-minute decoupling with time. Even after the curing lights turned off, bonds are still forming and the adhesive layer is still curing within the dentin. So what we'll do here is we'll spread out the Majesty Flow resin coat to cover all of the dentin in a very even fashion. You can use an Explorer tip, or you can use the PerioProbe, which mysteriously disappeared and now has reappeared. So if I turn the tooth this way, we can put that PerioProbe in there. We can see that this is probably actually more like 0.25 millimeters, which is great. What we're trying to do here is put a layer of resin over the adhesive that's just thin enough and doesn't touch any other walls, so that when we cure this, it just shrinks to the pulpal floor, the dentin floor. That's going to help us achieve a very secure bond to dentin. If you were to cure the adhesive layer and then start piling on a bunch of composite, that composite's going to start shrinking. And most people will place 1 to 2 millimeters of composite to quickly get the job done. Once you get up to the enamel, or if any of that composite touches the enamel, it's going to bond strongly to the enamel and then shrink towards the enamel, which causes it to shrink away from the weakest bond at that point in time, which is generally the dentin. So you risk delamination from the pulpal floor. Again, post-op sensitivity is not normal in composite. I mean, we have all these desensitizers that all these companies sell, like Gluma, as if post-op sensitivity is just supposed to be accepted and expected after you do a filling, and it's not. Post-op sensitivity shouldn't happen if you're doing your proper bonding steps and protocols and taking your time to allow these dentin bonds to form. And we are now. I mean, it's probably been about 2 to 3 minutes since I've been jabbing my mouth, and I've just started to place the final resin coat layers here on the proximal areas. Now these are the areas that are most prone to micro leakage and recurrent caries, as everybody knows. So by placing this resin coat in those areas now, we allow time for that bond to form, and that's fully sealed at this point. Now if I wanted to, I could take everything off and I can send the patient home. He'd have a big hole in his tooth, but he'd have no sensitivity because we've just sealed the entire tooth from the bottom. So if I turn this on, we can take a look here at the tooth, and that's a beautiful view of a very, very nice resin coat and the start of our biobase. So yeah, so to clarify, yes, you do. I mean, I placed it on the occlusal first, cured that, and then I placed, then I finished in the proximal areas. You could do it all at once to save time if you want to. And then you want to make sure you cover all of the dentin. So we have achieved that at this point, and then we're going to move on to the next step. So a lot of people ask, well, now do we build the proximal walls? If you wanted to build the proximal walls and turn this from, you know, an MOD class 2 restoration into just a class 1 restoration, you could build the proximal walls at this point. Should I do that? Do you want me to do that, or should I just move on with the placement of? I think these are going to be good. I think you guys probably. I'll go ahead and just do the proximal walls here because it's always a demonstration people enjoy seeing. Oh yeah, so proximal walls. We got to vote for proximal walls. No one said no. They said ribbon. Let me just do this real quick. It will only take a minute, and I'll actually fast forward it. I won't do what I normally would do clinically. We'll just kind of fast forward through this, but generally you just want to come in here and place your whatever sectional matrix you want to use. Place that, place your wedge. In this case I'm using a wooden wedge. And then at this point you can see that we have some separation of the teeth. We want to make sure that we get that contact there. So we'll place some material, and then we will build that proximal wall. So one of the things that I like to do in building my proximal walls is I'll take flowable here, and I will go in and I'll just line the borders here, and then what I'll do is I'll take my APX or whatever composite I'm going to use, and then I'll place that in there. Yeah, you want to make sure you have your dam inverted. If your dam's not inverted, then you don't have absolute isolation. Okay, so this is clearfill APX. What I'm going to do is I'm just going to essentially just inject this here just a little bit, and then I'm going to take my round condenser. I usually like to use my round condenser, and I will, well, of course I have some fuzz, so I'm going to go ahead and just start condensing this into place. A lot of people will advocate for just doing very small, a much smaller increment than what I just did, and you could do that. I'm trying to kind of make this a cooking show, so we're not sitting here all night long building proximal walls. But what I'll generally try to do here is just adapt this to the matrix, and the flow, laying the flowable down first in sort of that snowplow or injection molding, injection overmolding, whatever you want to call it, technique. allows you to have a really nice seal and adaptation of the composite to the tooth structure. So you can see that I've kind of pressed that composite up against the matrix there, and we may need to add a little bit more to build that a little higher. I'll sort of pinch this off. We just want enough to get the height, or the approximate height of the marginal ridge. We'll pinch that off. Okay. And then I have my assistant here who's going to help me cure. I don't have a separator, but what we can do here is just press this up against the adjacent tooth, and she will cure. Obviously, you know, we would use a separating ring to make sure that we get a really nice contact. But now that we've done that, we can go ahead and take the wedge out, and we can take that matrix out, and we can actually reuse this matrix on the other side if we want to save money for our practice. Okay. So I'm not too concerned right now with this Typodont tooth of getting a proximal contact. Like I said, we would use a separating ring clinically to make sure that we do that. I just don't have one here tonight because I didn't really plan on doing this. So we have that built now. Again, I'll go to the other side and I'll do the exact same thing again. We'll just go ahead and place that matrix on the other side. I'm going to take the flowable. Oh, yep, do need a wedge. My great assistant is keeping me honest. Okay. So we'll run the flowable down in all of the constriction areas and up. And we're going to take our clear fill APX again, and we're going to just inject down into the box. You can do this in any way you want to. If you have syringes, you can dispense it in the syringe and then place it in there. But the APX is really creamy, so generally I'll just put it straight in from the capsule. Same concept, clearing away the excess. Blending that in with the enamel. All right, and then I'm going to have my assistant come. She's going to cure for me. Yeah, not too concerned with getting a proximal contact in this case because I'm not using a separating ring. If I was, we'd have a really nice contact here. Okay, so now we have that proximal wall. And the nice thing about doing this step next is that 5-minute timer is now at what, 10 minutes? We've got the walls built now. And we've stayed away from the dentin, so we're not doing too much dentin bonding by building these proximal walls. And so now we have a class 1 restoration. And I know everybody's going to troll me for having this big open space right here, and I don't care because I wasn't trying to get a proximal contact, but you can see that I have one here on the distal. So send all of your complaints to Cat's Meow. He'll respond. All right, so here's the rib-on steps. So someone just asked me what kind of rib-on do you use, the ultra and what width. So there are different types of rib-on. This is the rib-on that we're using tonight is rib-on ultra. And so there's a variety of widths. I did have a piece here. And I believe this piece that I'm using here is this the 4mm?
Yeah.
So this is a 4mm, and what we'll do is we'll place this just right in here like this evening. And yeah, John, thanks for pointing out there's no contact. There's actually decay on the distal of the bicuspid that we're going to restore, so we'll just make that contact when we do that, right? That's always the answer. All right, so you want to read the manufacturer's instruction for use for rib-on. Rib-on will tell you that you want to wet the rib-on first, and they do have a special unfilled resin bond for doing that. But all you really need is the bond from your 2-bottle bonding system. You don't want to use you don't want to use like Scotch Bond Universal or any Universal, because that has the primer and the bond mixed in with it, so it's got a bunch of extra stuff. You just want to use either an unfilled resin, or you want to use the bonding step bonding resin from your 2-bottle system. So what Rib-On wants you to do, and yeah, should have gone with amalgam. What Rib-On wants you to do is wet the Rib-On first. And what we found is that when you wet the rib-on first, the rib-on will tend to curl on the ends, and it actually kind of stiffens up a little bit, and that might be by design, but I don't really like that it does that. So I'm going to show you kind of what we do instead. Let's go ahead and place the filter back on. So what I'll do here first is I'm going to place Clearfill APX down, a very thin layer of Clearfill APX, and the way that I'm going to do that is by using the same micro brush that I used for my adhesive. And I found that, you know, using a metal instrument is okay sometimes, but it can be sticky. So using a micro brush like this kind of just helps you adapt the APX to the floor without any pullback or without getting really messy. And again, you want to keep this layer as thin as possible, just enough to be able to press the rib-on down into. Now what's the goal here? The goal here is to get the rib-on as close to that resin coat layer as possible, because you don't want to have too much either flowable or APX composite in between the rib-on and the bottom of the tooth. That's just going to leave you vulnerable to voids, excess shrinkage, etc., which is what we're trying to avoid. So we'll do a very thin layer of this, and I like to adapt it down to the floor first. I'm going to turn down the light here to give you guys a little better view. Okay, now that that's in place, I'm going to take, I think we've switched to the 3mm for this cavity prep.
Yep.
And I'm just going to place this right here on the floor. Now you can place multiple pieces of this and they can overlap, but you do want it to be at least 1.5 millimeters below the occlusal. So now I have my bond or unfilled resin on the micro brush, and now that it's in place, I can press it into the APX layer and get it adapted as close to the tooth as possible. And I found that this is a little bit cleaner and easier than trying to wet it first and then manipulate the rib-on. When it's wet. So you can see that it kind of will slide around a little bit. I'm gonna rotate this so you have a different view. If I mag out, you might be able to see a little bit better. No, I think that was good. All right, so now that we've done that, we're gonna go ahead and cure. Now again, we're trying to mitigate the C factor issues. We're trying to reduce the shrinkage stress of the composite. Ultimately, we're increasing the fracture toughness of the restoration with the fiber in place. But this fiber layer is also going to act as a stress distribution layer. So you can know once we've cut through the enamel and the dentin and cut through the dentin and enamel junction, what we've done here is we've essentially restored the dentin and enamel junction with this layer of rib-on. Now, we could go in here, and maybe we should go in here and place rib-on in the proximal boxes. Does everybody agree that we should do that? That's an area where you're going to have the most leakage, and of course, and I think it was Samabelli's study, I can't remember, they showed that in the deep proximal boxes, placement of rib-on in those areas mitigated the shrinkage stress, but also the micro leakage in those areas. So my assistant's getting me, is that the 2 millimeter? A 2 millimeter section of rib-on. And again, you do want the rib-on scissors because this stuff's a pain to try to cut with regular scissors. So this is the 2 millimeter, and this is perfect for these proximal box areas. So again, and we could have done this. We probably should have done this. This is a good talking point. We probably should have done this before we cured that last step, so that it was all in the same layer of APX. But this restoration is already going to be better than the average filling that's out there, so I'm not too concerned. So let's go ahead and place a little bit of APX in those proximal boxes. I hope John's still watching, because he's just a very critical person, and I always like having him around. He points out all the obvious things, like my open contact. All right, so now we've placed the APX in the proximal box. I don't want too much because I'm trying to build a stress-reduced restoration. I don't want to induce any additional stress. So we'll go ahead and we'll place this very thin piece of rib-on in the proximal box, and then we'll place another one on the mesial. We'll do this together. Like I said, I would have done this all at the same time when I did this first one here, but I got carried away. Okay, so my assistant's going to give me my microbrush with just the bond, and I might, like, sometimes you just have to kind of dab that on something so that you don't have too much excess bond or resin, unfilled resin. We're just going to sink that down into the APX. We'll go ahead and clean up any excess composite that squirts out. What's that called, Dr. Kim? The Poisson effect? Is that the Poisson effect? Okay. And then we'll go ahead and we'll cure that. So at this point, you know, I've placed the rib-on, and we placed 2 different sizes of rib-on. But again, you know, there's multiple different ways of doing this, and everybody does it a little bit differently. The thing you want to keep in mind is that you want the rib-on as close to the tooth as possible. Now, Rib-On has some great videos on their website that show a technique or a couple techniques that they seem to approve. They don't show placing the resin coat, Majesty Flow or any type of flowable over the adhesive layer first. They'll actually advocate for just placing the adhesive to create that hybrid layer, and then going in with they use a different composite, but it would be like the APX over the top of that, and then pressing the rib-on down into the APX to get the rib-on as close to that dentin substrate surface as possible. In this case, we have a resin coat layer of flowable in between the dentin and the rib-on layer. All right, so now you can see that we have that rib-on layer in place, and then we can, from here, we can just go ahead and start building our restoration up and just restoring the tooth. It's been well over 5 minutes, so we can be pretty certain that that hybrid layer at the dentin layer is very secure. And with the rib-on now in place, we've recreated the DEC or the DEJ as a stress distribution layer. And now we can start to incrementally build up the rest of our dentin replacement layer, and then our enamel replacement. So we'll do about a millimeter of APX just to complete that dentin replacement over the top of the rib-on. And I'll give you a different view here so you can kind of see depth. It's hard to see depth when you're looking straight down on an object. I'm always amazed if you follow Dr. Steve Schiffenhaus and you watch his onlays and overlays and stuff. He takes beautiful photographs, but when you're looking down at the tooth, you can't appreciate the artistry and the beauty behind those preparations. You always have to look at them from a side view like this to really see the three-dimensional view of it. So we've got that in place. Now something that you'll see a lot of for people that use like Delabit or Olabit method of replacing, especially the enamel, is you might see some clinicians at this point sort of draw in guides for their final anatomy, if the final anatomy is something that you want to place in your final restorations. You might see people sort of come in here and draw in some anatomy. And of course, this is a maxillary first molar, so we remember what that anatomy should look like with our oblique ridge and all that good stuff. You probably can't see that. We'll go ahead and cure this. You want to have a really high quality curing light, not one that you bought off Amazon. You want to keep the batteries nice and fully charged on it, and you want to cure for a full 20 to 30 seconds. You can't really over cure composite. And remember, the composite is a thermo insulator, so now that we have a pretty thick layer of composite over the pulpal floor. Not a lot of heat's going to be transmitted to the pulp by curing this. All right, so now what we can do is our final enamel replacement layer, and I'm just going to finish using the APX. Let's go ahead and make a couple olivets, just little balls that we can roll up and put in place to sort of recreate our typodont tooth. Put a little ball there. Again, I'll use the micro brush to sort of adapt this into place. People will use endo files to get really fine details. There are special instruments that you can buy to do this kind of artistry. I feel like it's not a very important aspect of restoring a tooth because secondary, tertiary anatomy in terms of function is sort of irrelevant, but it looks good on Instagram, so we can always restore the tooth. I mean, no one's ever gonna jump in someone's mouth and look at this beautiful anatomy, but we'll do it anyway because that's the kind of people that we are. So again, we want to try to match the anatomy of the adjacent tooth. We actually teach an injection overmolding technique for the enamel replacement. And in that technique, all we're trying to do is recreate primary anatomy. That's how we get a very nice, smooth, high shine polish on the restoration. And you know, patients love that feeling, to be honest. I've done these restorations where I've put in a lot of really nice anatomy and tried to restore the tooth to a natural look. And at the end, you know, the patient will feel it with their tongue and they'll say, oh, it feels rough. With the injection overmolding technique, you know, it's we always get comments that things are so nice and smooth, and they want us to polish their adjacent teeth because their adjacent teeth are always rougher. So again, you got to remember that there's doctor-centered outcomes and there's patient-centered outcomes. And I think that when it comes to doing all this really intricate anatomy and staining, I feel like that's more of a doctor-centered outcome because it's not going to impact the function of the tooth. Unless the patient asks for it, then it would be a patient-centered outcome. But again, I have a lot of respect for the people that do it and their artistic ability to do it because it's not really easy. So we're going to just recreate the oblique ridge here. Again, at this point, you know, I'm just playing. Sometimes there is a groove across that. Oblique ridge. Sometimes there isn't. We can look at the second molar. They've designed that tooth to have a groove across the marginal ridge. Okay, we'll go ahead and cure that. Regardless of how the outside of this tooth looks, this restoration is going to last a long time because we've bonded everything very, very securely from the bottom to the top. And aside from my open contacts, I think this is going to be a very, very happy patient. So we'll just finish off with the mesial palatal cusp here. Again, I'm just showing the use of just a couple different instruments and kind of how I would go about doing this without having like expensive specialty equipment, although I do have a lot of specialty stuff because I'm just a nerd in that way. But I think that Cat's Meow has more. He knows how to get all the good deals. So if you guys want good deals or you want to know where to find good deals, usually he actually can find really good materials for really good rates. So DM and follow Cat's Meow. He's the guy that will never change his Instagram name because we all love his Instagram name too much. Sorry, Ken. You're stuck with it. Again, you want to cure these final layers for, a good 15-20 seconds, fully cure. I'll turn the filter off, and that's kind of where we're going with things. You guys seen that meme on it's all over Instagram where it's like your restoration when you take all the time to put the anatomy in it, and then the restoration after occlusal adjustment. Dr. Kim has a case that she just did. I think she's going to post it soon. She rebuilt a tooth. The Schiffenhaus probably would have done an onlay. She rebuilt the tooth direct. It's a beautiful restoration, and she took the rubber dam off and everything, and she had perfect occlusion. Didn't have to adjust anything. So if everybody who's watching is probably following the Disking Queen. You're gonna want to be on the lookout for that post. She uses Ribond in that as well. And that is one lucky patient, to be honest with you. I can't believe what she was able to achieve. But that is the Disking Queen for you. Always pushing the boundaries. Again, injectionovermolding.com. We have advanced posterior course coming up, 2 of them, and 2 anterior courses. Actually, one of the anterior courses just sold out tonight. And we actually had to add 1 seat for per request. So you guys might want to jump on board. Come hang out with us in Seattle. Anterior aesthetics courses are a full day, 10 CE credits. And the advanced posterior course is a 2-day course. Cat's Meow is one of our guest hands-on instructors. You get to hang out with the man himself. Drives all the way up from Centralia, shuts his practice down just to come hang out with us and talk about biomimetic dentistry. What a great guy. We all love Ken. We got a great group of clinicians signed up from all over Washington, Oregon, some folks flying in from Florida, South Carolina. We have global microscopes. We have be in your handpieces, electric handpieces. Everybody gets to use the electric handpieces. We have a live patient demo for both courses. So Dr. Kim will do a posterior restoration. Oftentimes it's a deep crack dissection. It's always fun to see her sort of think critically and analyze and make decisions on the fly. These are often live patients that Dr. Kim knows have issues, but she hasn't necessarily treatment planned them or thought things through in detail prior to the course. So you get to sit with her in the operatory and watch the big screen microscope feed as she talks through rubber dam placement, local anesthetic delivery, preparation and restoration, along with crack dissections and other things that pop up along the way. Burr block for Canada, I don't think it's available. Comet USA doesn't deal directly with Canada, but if you want to buy the Biomedic Burr block, I can sell it to you and I can ship it to Canada for you if you want to pay for the shipping. I'm happy to do it. Just shoot me a DM and I'll get you all the information. These burr blocks have gone all the way to New Zealand, Philippines, and the UK. So always happy to spread the love of just a really high quality burrs from Comet. And of course, if you want to try out some of the Comet products, you can use my my discount code for 30% off. The discount code is disruptor at cometusa.com. All right, so there is our final restoration, and now all we need to do is go in here and just clean things up a little bit. So let me bump out a little bit. Yeah, I do have an open contact, but I don't care. The first thing that we'll do is we'll come here and we'll clean up any excess composite with the disc. Being careful not to go all the way into the embrasure space because we want to maintain, very natural contour. So, with those matrices placed, that flowable composite gets pressed out to the line angles, and we just have to blend that in with the disc to the enamel. Once the disc gets softened up here, we can round those marginal ridges, make them nice and round to remove as much opportunity for tension in those areas to prevent the marginal ridges from fracturing. So if we look at this from a side view, we can see we're getting a very nice rounded marginal ridge. And I actually don't mind having this open contact here for the demonstration because we can get a good visualization of what it looks like in approximately. So look at that. Okay, now if you wanted to leave, you can see that there's just a slight void. Now let's say I don't want to ruin my my contour here, but I do see that there's a void at that line angle. If I bump up, you'll see it too. There's a little void there. So we can take a little bit of adhesive at this point and place it here. And then we can take some flowable composite. We can just do a little bit of augmentation in that area. And then what we do is we'll just take like an explorer and just sort of tease that into that void. Sort of blend things in. And then cure, and then we don't have to chase after that defect and then alter the contour of our restoration. All right. So now we can keep that, and again, I can go back to 12,000 with my disc. And kind of finish that off. Try to blend that in. And again, on the other side, doing the same thing. And how do we achieve those rounded rounded marginal ridges? With the disc, once it's soft, just gently rounding those marginal ridges just like that. Okay. Now let's blow all the air off here. Let's take a look. Now at this point, what I'll do is I'll take the H48 LQ on my high speed, and I'll run this burr. I'll show you the burr here in just a minute. I'll run this. This is the Q finisher, the yellow and blue striper. This is a crosscut carbide, and it's kind of an acorn or a Christmas tree shape. This is great for occlusal anatomy. I'll run this at about 12,000 RPM. And I just like to go in here and just kind of blend in any of the composite to the enamel. Just sort of fine tune any of the rough spots, because this Q finisher is pressure sensitive. It'll cut really well if you put some pressure on it, but if you use it like I am now, it does a really nice job of sort of doing a pre-polish. And this is the first step to the polishing technique that we teach, which is very simple. So this will give you a really nice sort of matte finish. Okay, coming up to the end here. Now at this stage, what we would normally use is it's called a contour anatomy trimmer, but an enhanced point or cup works very well too. I'll use an enhance to finish off the pre-polish. I'm going to use this at about 6,000 RPM. Very light pressure. This is going to give us a very nice matte finish. And it'll help us understand if we've blended our composite properly and fully into the enamel. Sort of achieve seamless margins. I just got it wrapped up in my rubber dam. Be careful about that. So let's finish that off. And our marginal ridges roughly the same height of the adjacent teeth. They are. Good. Now people will ask me, do you do that with or without water? I'll generally do it without water because I like to see where I'm at. Okay. And now from there, the last step, and you want to use high volume air water spray with this. The nice thing about the B&Air hand pieces is that they'll spray air and water out of the tip, right out of here. So your assistant just has to suction. You want to run this one-step polishing cup. You just want to run it at about 6,000 RPM. And I'll use the cup. There's a point, but I like to use the cup. The cup is in the biomimetic burr block. The cup you can use in multiple different angles and applications. But I want to show you, I'm going to polish the mesial part of this tooth, and I want to show you the difference between that matte finish that's created with the Q finisher and like the enhanced cup, and the difference between what's created with the one-step polisher. And again, when you use air water spray, you're going to get an even higher shine polish on there. Okay. So again, we'll go back in here. Light pressure, very light pressure. Again, the air water spray is to keep not just the tooth cool, but also keep the diamond impregnated cup cool as well. This is meant to be a multi-use cup, so you know, if you treat it well, it will withstand multiple uses and multiple teeth. I'll come in here often. I'll come in here and I'll do the embrasure spaces, just like that. And on the buckle, just like that. And there's our restoration. We can remove the rubber dam, and then we can do our final lesson 6 occlusion checks and all that good stuff. Here's a buckle view. Beautiful open contacts. Nice, very nice, natural contours that we've been able to create. And of course we have some nice natural occlusal anatomy. But you know, this restoration is built to last from the bottom to the top, from the hybrid layer where we used Clearfill SE Protect, double bottle gold standard adhesive system, followed by Majesty Flow for the resin coat, and then an APX Ribond layer in the middle for stress distribution, for a very high strength hybrid layer, and to mitigate C-factor stresses and issues, followed by completion of the dentin replacement layer with clear fill APX, and then the enamel replacement layer. Now the enamel replacement layer, once you get to the top, you can do whatever it is that you like to do for enamel replacement. In this demonstration, I used a combination of sort of some balls rolled, which we refer to as delibits or olibits, and then just straight injection into the cavity to adapt the composite with instruments, microbrushes, and an Explorer tip. Here in Washington at the Institute of Injection Overmolding, injectionovermolding.com/store. Check out our courses. They're filling up pretty quickly, but we do teach the injection overmolding technique of injection overmolding, the final 1.5 to 2 millimeters of enamel replacement on the top, which will help you achieve a really nice high shine polish that is stain resistant and fracture resistant, and just a very comfortable restoration for the patient. If you're an indirect person, you might choose to do an indirect on-lay or overlay, an Emax, bonded Emax for your final enamel replacement layer. But at the end of the day, we can be certain that by restoring the tooth in this manner, this restoration is going to be built to last for a very long time. And aside from the open contact that I created without using a separating ring, we're probably going to have a very happy patient. At least they'll be able to clean in between the teeth just fine, right? All right, so at this time, does anybody have any questions? I still have 19 people here. Thank you, everybody. I think we had 50 here initially. Appreciate you guys joining in tonight and let me share some knowledge on tooth preparation, some dental materials, really high quality dental materials that are highly supported by pretty solid research. You've got a pretty in-depth look into the biomimetic mastership program, which I attended last June. That's a pretty solid program done by Dr. David and his son Davey Alleman. If you really want to learn this information in detail and in depth, and you want to go over 120 articles that support everything that I just did tonight, then contact them and get on board with the mastership program. It'll change your dentistry forever. I also mentioned Dr. Steve Schiffenhaus. Steve and I oftentimes do BRD After Dark together. I attended his indirect overlay online course down in Arizona. He has an online program, the Bard Institute. Really nice content, and Steve is just a very skilled clinician, but he's also very knowledgeable in biomimetics. So check out the Bard Institute. Very nice program that he has online. It's very convenient and it's not too expensive. So if you're looking to just kind of dip your fingers in the world of biomimetic dentistry, check that out. And also check out the Academy of Biomimetic Dentistry. They hold webinars regularly that are free. Become an Academy of Biomimetic Dentistry member and join the movement. It's fun to do dentistry this way. And when your patients see what you're doing and you talk to them about what you're doing, they really appreciate the work that you do. That being said, if there's no other questions, I'm gonna finish my drink that I wasn't able to tend to during the demo. And again, come join us, injectionovermolding.com. We'd love to have you in Seattle. Our courses only host about 6 clinicians, so we keep the class size very small. There's 3 instructors, Dr. Kim, myself, and Dr. Yi. We're all dentists. Very nice doctor to student ratio for those of you interested in coming for some lecture. some really intense hands-on and a live patient demo that's done by Dr. Kim right there during the course. The Advanced Posterior course is also guest lectured and taught by Davey Allman in from Utah. We have a lot of fun over 2 days. That course is filling up quick. We've got 3 spots left for the upcoming, I think it's the June course. And then there's a couple spots left in the August course. So check out injectionovermolding.com/events or /store. If you want to bring your assistants, your FDAs, we are always happy to have them come along. We offer discounted rates for FDAs and assistants, even restorative hygienists who want to learn some anterior aesthetic stuff, black triangle closures, learn to be able to talk to patients about these additive techniques, which is a huge game changer for practices. We love having everybody in. We love having people from all over the country that use all kinds of different materials. We have no conflicts of interest. We try to teach as many materials as we can find, as many matrix systems as we can find, as many composites that we can find, as many adhesive systems that we can find. Of course, we have our favorites, and we'll always teach what the science supports, but we understand that doctors come from all over the place, from different types of clinics, from private practice to public health, and sometimes you don't have control over what materials you use. So we always advocate for doctors coming in with either a list of what they have in the clinic or to bring their materials with them, and then we help teach them how to use them optimally or to use them better with biomimetic protocols. Even though the materials may not be ideal, there is still ideal or optimal ways to use those materials. So we don't judge anybody. We try to help everybody out, and we all end up learning from each other, from people that come all over the place. One of the reasons why I like doing the courses and being an educator is because I learn something new from everybody else. And Instagram and these live demos give me an opportunity to improve my own knowledge in my own dentistry. So again, to the 11 of you that are still here, I appreciate your followership and your support. And if you have any requests for any demos that you'd like to see us do, please send me a DM, and I'd be happy to do that for you. Stay tuned. Dr. Kim is gonna be up next before the end of the week. She's gonna do a really cool demo on using the saddle matrix, which she really enjoys. This is a really unique matrix system that a lot of people are using and showing in some of their cases. And Dr. Kim has obtained a saddle matrix and has been using it a lot lately in her clinical practice. So she's going to jump on here in the same format that I just did this, and she's going to show you how to do some matrixing with the saddle matrix. So stay tuned for that. It's going to be on @DiscingQueen either tomorrow or Friday. And again, we always appreciate you guys, and we'll see you next time.